I know Dr. Jacques now for about 7-8 years, and I first had really honor of meeting her at one of these national conferences, which was superb because annually, we kind of go to these events and meet people and learn from each other. And the first thing that hit me was really the wealth of knowledge she had. And that has always been the case. I've learned a lot from her. She's a doctorate in nutrition. She will tell you all her qualifications herself.
Wow.
And very well informed, very unbiased.
So there's all kinds of reasons that people have, challenges with nutrition after surgery. And just curious, because I know that there's more than one kind of procedure in here, but anybody with band? Anybody with band? Anybody with a sleeve? All right, lots of you. Anybody with a gastric bypass? Anybody who hasn't had surgery is preparing for surgery or, okay, all right, excellent. We have a good mix. I like that. After surgery, people eat less food. Okay? This is a very simple reason why we end up with nutritional deficiencies. So if we start out, and I'll talk a little bit about pre-existing deficiency with people who may have a little bit of low nutrition, and we have less food that you're taking in because you've had bariatric surgery, now the risk for developing a problem just becomes that much higher. And people eat differently after surgery. How many of you have had surgery eat differently now than the way that you ate before surgery? Right, so it's pretty common that people change the way that they eat. And that can be for a lot of reasons. Sometimes it's because you've been given some instruction from your dietitian or your doctor about how to eat differently. There may be foods that you don't tolerate as well now as you were able to tolerate before. So a lot of different things can lead up to that. Actually, when we study, we find that by and large people eat much better after surgery than they did before surgery. And that's in part because you're making more careful choices. But the changes in diet can also reflect the nutrients that people get. Anytime we start rearranging the way that we were originally put together on the inside and making it different, we just create a little extra barrier for vitamins and minerals to get into the body. So whether that is removing or bypassing part of the stomach or bypassing part of the small intestine, as we do with a sleeve gastrectomy or with a gastric bypass, we just create sort of an additional barrier. So protein is interesting because its process actually starts in the stomach. So the stomach is really important for protein. And we actually do our first breakdown with acid and an enzyme in the stomach. And actually whole proteins, by the time they leave the stomach in normal anatomy, are broken down about 40% of them completely, all the way to their smallest component. Okay, so you can imagine in a gastric bypass where we now just have this little tiny pouch, or even in a sleeve, some part of that process is going to be changed, right? Then if we do some bypassing, like in a gastric bypass, we actually start to then bypass some of the places where those amino acids, the components of protein, would be absorbed. So the longer a bypass is, the more challenging that can be. So we have some changes both to digestion, that's what's happening up in the stomach, and potentially, depending on a procedure, to absorption. Now the good news is that those little components of proteins, amino acids, are actually absorbed through the entire small intestine. So they're absorbed really well everywhere. So we almost never see a real protein malnutrition with any of the procedures that are being done here. Have you ever seen one in your years of, you've been practicing a long time, right? You've probably never seen one. So that tells me two things. It tells me your body is really smart and it tries to get what it needs. And by and large, people get the message about protein and that it's really important for them to do after surgery, and they pay attention to it, okay? And so these cases, we tend to only really see these clinical cases of protein malnutrition, either in people who really stop taking care of themselves, who get sick with something else for another reason, so they get another illness on top of having had weight loss surgery, or they have one of these very malabsorptive procedures like a duodenal switch. That's really the only places we tend to see it. So anybody here 2, 3, 4 years out of surgery? Anybody? So after a little while, your range of foods that you can eat really expands, right? But what we find when we study people who are further out of surgery is that while the range of foods that they can eat expands, usually the calories they take in or the amount of food they consume doesn't change all that much. So they've done long-term studies of patients and really shown that gastric bypass patients, for example, rarely ever get above on a regular basis 12 or 1,300 calories a day. That's really small for long-term life intake. But what does happen is people can eat more diversity. They start to include more foods in their diet, and the proportion of protein they're eating may drop. So we see some studies like this where we may see that 10, 15, 20% of people on a daily basis may not always be meeting their protein needs. So I think the message that I would give is that this is something that I think people tend to do a really good job with the first couple of years after surgery. And as you start to get past that point, you may really need to watch yourself a little bit more carefully on a day-to-day basis and make sure that you're getting it. Is it okay to not get your protein in 100% of the time? Okay, just don't listen. Where's the dietitian? Tell her not to listen for a second. Yeah, if you do it for a day, do it for a couple of days, is it going to hurt you? No. If you do it for a couple of months, is it going to hurt you? Yes. Vitamin B12 is a deficiency that we certainly see in both sleeve gastrectomy and in gastric bypass. We see it at about the same rates in both of those procedures, and that's because we operate on the stomach. So the stomach plays a really important role in how B12 is absorbed in the body, and for a couple of reasons. One is most of the protein in your diet most of the B12 in your diet is bound to protein, and when we take that in food, your body has to use acid to separate the B12 and the protein. So we don't have as much time or contact with acid in those procedures, either because we've bypassed significant parts of the stomach or we've removed part of the stomach, and so that process changed. But the really key thing is this little thing called IF, or intrinsic factor. This is made by specialized cells in the stomach, and in order to absorb B12, we have this really interesting system where we break it out of food and then we bind it to this stuff called B12, and that stuff travels all the way through to the most distal part of your small intestine, and it's actually that complex that by and large gets absorption done. So in gastric bypass, all of the area where that substance is made is bypassed. So you just get no contact with it anymore. And in sleeve gastrectomy, most of the cells that make intrinsic factor are actually removed. So it really makes a big difference. And we can see rates be very high in people who are unsupplemented for B12 deficiency in both of these procedures for that reason. So can the body still absorb some B12 without intrinsic factor? Yes, but it's about 1 to 3%. So it's a really small amount. So usually your doctor will recommend that you do something else. It might be injection, it might be prescription nasal spray, it might be a sublingual tablet. And this is one where, you basically, if you've had a sleeve or you've had a gastric bypass, you will do it for the rest of your life. We do see deficiencies at some of our other procedures, but at much, much, much lower rates than in those two procedures, because it's the operation on the stomach that really makes the big difference for this particular nutrient. So when we see B12 deficiency, it can be quite what I call insidious in onset, because you actually store some B12 in your liver. So this can take a very long time to develop if it's going to happen. So that's another thing that can be deceptive, is people's levels can be fine, and then at 5 years, 7 years, 8 years, it can take a long time. And this because usually if we catch something like this early, we can get it turned around very quickly. It's when people let it go on for a really long time and they don't report it that actually some of the damage can become permanent. This is really, especially for those of you preparing for surgery, this is a good one to know about. The biggest risk for thiamine deficiency is in 0 to 6 months after surgery, and is particularly in patients who have vomiting after surgery. So, is it common to have a little occasional vomiting once in a while? As people are kind of getting used to their procedure, it can happen. Should it be happening? Should people have persistent nausea and be vomiting on any kind of regular basis? No, you should not be doing that. And that's actually something that you need to report right away if it happens. Thiamine deficiency, if people are vomiting, can happen really, really fast. Okay, so B12, I said, we store some of that. You actually put some of it away in your liver. You could kind of go, I don't want you to, but you could probably go a few months and you'd be okay, right? B1, you store about 7 days worth. That's it, okay? But because it is associated with early post-operative complications, things like stricture that can cause vomiting or other things like that, that's really where we see the most acute problem, and that can develop with a very rapid onset of changes in the nervous system, which can occasionally be fatal. So that's why it's really important to occur this. Now the rate is very low, less than 1% worldwide. Okay, so this is very low. We do see some chronic deficiency as well. I said that. And we still are learning a little bit about that. It appears to be mostly, again, either in people who just completely stop taking care of themselves or people who would be abusing alcohol after surgery. Protein does a bunch of stuff, right? We build muscle with it, it's part of our immune function, we do tissue repair with it, but one of the other things it does is it carries vitamin A around your body. Okay, so it carries some other things around your body. And if you're not taking in enough on kind of a chronic basis, protein will do its most important jobs and kind of get lazy with its less important jobs. So apparently carrying vitamin A around is a less important job than keeping your muscle healthy and doing tissue repair, which is probably good overall, but it's not good long term. So actually what they found in these patients is they really didn't have what I would call real vitamin A deficiency. They had not enough protein to get the vitamin A moving around in their bloodstream so that when their doctors drew their blood, they couldn't see it. Does that make sense to people? And once they got their protein levels back up, once they got them taking in more protein, suddenly that vitamin A sort of reappears because they're now carrying it around in their body. We need enough vitamin D both to properly absorb calcium and also to tell calcium what to do. So meaning without enough vitamin D, calcium's just not as smart. It doesn't necessarily know that it should go to your bone without enough vitamin D. So it really does both things. And vitamin D deficiency is, first of all, it's extremely common before surgery. And the numbers would actually have it that it's more common before surgery than it is after surgery. So it's highly, highly, highly associated with obesity. And even left alone, just as people lose weight, their vitamin D levels tend to rise, especially during the time people are actively losing weight. Can anybody guess why? Anybody with a good guess why?
The fat?
Yeah, the fat.
Sure.
So vitamin D is fat soluble, okay? And fat soluble vitamins store in fat, right? So as people lose fat tissue, they actually free up their own vitamin D. And it goes back into circulation. So a lot of times people have it, but they can't use it. It's kind of like when you didn't have the protein to carry the vitamin A around. We find it's there, and as people go through, especially a period of rapid weight loss, their levels will tend to rise naturally, and when weight loss stabilizes, it will tend to flatten out. So again, that's still really common, right? Half of patients still being potentially vitamin D deficiency at 2 years, and we're still trying to learn a lot about why that is. But even though our recommendations for taking vitamin D, if the formal ones range from about 600 IUs up to about 2,000, it's not at all uncommon to see people after surgery taking 5,000, 10,000, even 50, and that's because that's really constant treatment to sort of keep these levels up because deficiency is so very common. For calcium, I want to talk about this for a minute, and this is something that I know, Dr. Yadegar, you were talking about, how do you help people do things long time? Calcium, this is hard. The levels of calcium that we ask people to take after surgery are very high. Kind of on the low end, usually 12 or 1,500 milligrams a day. On the high end, maybe 2,000-ish. And we ask people most of the time to take calcium citrate, which means they're taking a lot of pills. And this is a hard thing to do day in and day out. So, this is something maybe we want to talk about when I open up for some questions, is what are some strategies for being more or less successful with that? Because it is really important. Bone loss is a really big long-term risk with bariatric surgery, with all of our bariatric surgeries. And bone loss is silent. It doesn't hurt, it doesn't feel bad, it doesn't do anything obvious in most people. It's like just a quiet thing, and the reason it's quiet is you've got pretty good storage. You've got a whole skeleton, right? And I always say if it hurt every time you lost a little calcium from your bones, people would probably be a whole lot better about taking calcium, but it doesn't. It doesn't hurt at all. You don't feel it. And oftentimes the first thing that people feel is break of the bone. So it is one of the places where we do have to be really vigilant with prevention. I think it's one of the hardest things to do preventively because you might be taking 3, 4, 5 calcium pills a day, and that can be challenging to do. Now here is a challenge that we face. Your body does not think your hair is important. I'm going to be really honest. You think your hair is important, right? I think my hair is important. I like looking in the mirror and seeing my hair. Okay, and most of us think our hair is important, but your body really does not care much about your hair. When it comes to iron, what your body cares about is being able to make blood cells. Okay, and when your doctors look at labs, and this is no fault to doctors, this is how we all look at it, usually the thing that they're looking for a lot of time is something called ferritin. And usually the level of ferritin at where a laboratory draws the line and says, below this number you have deficiency, is the level at which you stop putting iron into red blood cells. Okay, that's where the lab draws the line. Now, so that's because red blood cells are more important than your hair. Okay, so that level might be 10 or 12. Okay, that's where that might be. But to have healthy hair for both men and women, you typically need a ferritin above 35. So no lab I know of will call that iron deficient. So you can actually have just a low enough ferritin that your body stops making hair properly, but you're still making plenty of blood cells. Okay, so prevalence is pretty high. So in gastric bypass, in people who are out quite a number of years, the ASMBS reports the average rate of deficiency about 36% of patients having some experience of iron deficiency. So if you end up with iron deficiency, just know you're not alone. And it's almost like sometimes we see people who are almost like programmed to become iron deficiency. Some people never get it. Some people it's like they were just going to get there no matter what. Higher rates in women with menstrual periods and in people who started out at a higher weight. Okay, so patients who started out heavier actually have a higher risk. With sleeve, we are just sort of learning here, but it looks like over the long run, maybe rates of deficiency around 15 to 18%. So again, not as high as gastric bypass, but higher than we would predict for a procedure that doesn't bypass the small intestine. Omega-3s, our sources of them tend to be things like certain fatty nuts, high-fat fish like salmon or mackerel or things like that. And we don't tend to generally, as a society, do nearly as well at getting the amounts of them as we need. So I already told you they're essential. So when we don't have enough of them, things can go wrong. And very important for brain tissue. Also very important for the heart and cardiovascular system. So important that some people's cardiologists now actually prescribe them. There's actually a drug now called Lavaza, which is a prescription form of fish oil. It's exactly what it is. The prescription form of the oils that we take out of fish that is used to do things like lower triglycerides, which are one of the fats in the blood. So very important for the heart and cardiovascular system. And they also do a host of other things. They're important for your skin, and they're important for certain areas of hormone regulation. They're important for how we regulate inflammation in the body. So if you don't have enough omega-3s, people tend to have more problems with pain, more problems with inflammation. So the range, because they're essential, the range of what they do, I always say I can't tell you all the functions of zinc because it's in like 235 enzymes in the body. So I hate talking about zinc deficiency because it does too many things. And omega-3 fatty acids are almost as big because they do so many things. So, and because these supplements have become so popular, you're also seeing them show up in other creative places. And so I'll tell you one of my personal biased favorites. I love omega-3 fortified eggs. I'm a huge fan. You get a little 70-calorie package of protein, and they have come up with a very clever way to feed chickens so that those yolks end up really high in omega-3 fatty acids. And it's just a lovely, if you're eating eggs as part of what you do, I think the top brand that's out there is Eggland's Best, but I think Trader Joe's has their own brand as well, and there's a few others. They don't pay me to say this. They're also the best tasting egg. I think for me, they've got beautiful, like bright orange yolks, because the yolk is really well nourished, and they just taste really good. Okay, now they should give me I should get like a kickback for doing that, but they're really good. You can find yogurts now that are omega-3 fortified. So what I tend to encourage people is look for diverse ways. If you're not a big fish eater especially, look for some good diverse ways you can get them in your diet and try to do it every day if you can.
Actually, I have a box of those on my desk.
You do? I heard that today that you munch on them.
I munch on those, so they're lovely.
You do. Okay.
It's durable omega-3s they have.
So I've taken up all my time that you've given me already.
It's fantastic.
Okay.
Really.
So I'm going to let you talk. Thank you.